Welcome to the impact session. Oh, chilling effect on the conversation. Yeah, I'm just going to do a brief introduction to impact, and then we can move forward with a little group session. We may wind up wanting to kind of cluster a little bit on in front for the group session. So I'm going to just introduce you to the impact program. We're a brand new program within CTSI. We've been around for about 6 to 9 months, and we are building our portfolio of services, and a lot of what we want to talk about today are the services that we offer. We are the Impacting Policy and Accelerating Translation Program. That's how our acronym spells out. And it's really a group of UCSF faculty and staff who are interested in working directly with policymakers to translate science effectively for policymaking. We're also interested in changing the culture at UCSF so that scientists are trained and learners are trained to be more able to speak with policymakers, identify policy issues, and move evidence into that sphere in a way that works for people in the policy realm. At a later stage, we're going to be providing resources for policymakers, particularly at the state level. So this is what people in translational sciences refer to as the spectrum of translation. It starts with basic research, and the goal between T1 and T2 science is to just get information out of the lab and into clinical trials, often for patients, for human research out of rat research. And then T2 is translating, say, new medications, procedures into clinical trials. T3 is getting those trials out of labs and into clinical practice. T4 is getting that clinical practice innovations out into the community. We are inventing T5 with the impact program. There are about 60 CTSAs in the country, and we're the only one with a program of this kind, where we're really interested in taking the translational spectrum to its logical endpoint, which is to translate evidence for governmental and non-governmental policymakers. Really important for this group, there are a lot of different kinds of policymakers, and we think about policymaking quite broadly. Most people, when you talk about policy, they immediately think of elected officials and governmental entities. That's what you would call big P policymakers. But in fact, a lot of the most important work that goes on in government is actually small p policymaking, which is really happening in the agencies within government that are actually implementing large policies on the ground, the Health Department of California being a good example. We've also got non-governmental policies, so this could be clinic and health systems policies, as well as professional guidelines that come out of professional organizations, such as the California Medical Association. So the impact program, we have 3 overarching aims, and the first one is to influence real-world decision-making by using data and science to inform the work that people in the real world are doing. The second is to provide UCSF faculty and staff with resources and training so that they can know how to engage a broad range of stakeholders and quicken the pace, accelerate the pace between the generation of science and the actual use of evidence in policymaking across all different sectors of decision making. And then finally, we're interested in fostering institutional reforms that change the way that we do things at the university. For example, thinking about how faculty get promoted, or how people are recruited to the university, or what learners and scientists are rewarded for? Is it just peer-reviewed publications, or are there other things that we can be rewarding scientists for, such as working directly with policymakers to bring evidence to a policy process and actually get change to occur? I got my start in this area about 15 years ago, working with lawmakers in San Francisco to pass one of the first soda taxes in the United States. I worked with people on the Board of Supervisors, the Health Department, and many stakeholders. It's one of the this is a tax that now generates millions of dollars every year for community-based health innovations around chronic disease prevention. Probably one of the most impactful things that I ever did in my career, to impact that many lives and that many programs with soda tax dollars that fund that work. And it's not something that I got promoted for. Papers in JAMA, NIH grants, yes, but innovative new policies, it's a different story. So how can we make our institution more friendly and even to support and reward people for thinking about how we bring innovations from the scientific community out into policymaking? We have thought a lot about our guiding principles. This is, as I mentioned, a new area, and even for translational science, it's a new area to be thinking about. And we've adopted some principles from community engagement to kind of steer us. But at the end of the day, the most important thing is to think about our obligation. We are in a state of California tax-funded university. Most of our research dollars come from the federal government in tax dollars. And so what is our obligation? To give back to those taxpayers in ways that shape the world and the context in which they live and improve the circumstances that drive health and health equity. So the impact program's #1 principle is that we have an obligation to share what we know and what we're learning with people in positions of power in decision making. We also think that scientists could do a much better job at trying to understand and imagine what it's like to be in government and to be in health system decision-making roles, and that we can do a lot better to adapt ourselves to the constraints that decision makers are under. In my experience, if you're working with, say, politicians on a policy change, you need to actually have their legislative aides and people on your cell phone, and sometimes they need to talk at 10 p.m. because the next morning they've got to get something into a briefing, or they need testimony in a moment's notice. So there's a lot about just understanding the constraints and the speed at which policy changes happen and being able to adapt ourselves to that. We think that we can form authentic partnerships, and particularly around values that we share with decision makers around health and equity and quality and value. We think that it's important to really think broadly about policymaking and to consider a wide range of decision makers in institutions, communities, and government. And then finally, we think that UCSF has an obligation in this area. We're a public university with a public service mission, and if we're not taking the best of our science and packaging it in ways that are useful to large institutions that shape the world around us, then we're not doing our jobs properly. We've also thought a little bit about how can we train and cultivate scientists who are able to do this kind of work. We like to call it impact-oriented science, and a lot of it comes down to sort of 4 areas, and these are really learning competencies that we're going to be developing training programs, and these are the competencies that drive our training agenda. How do you go about growing a career in this space when there are a lot of institutional imperatives and incentives that drive people back into the ivory tower. So there are ways to navigate a career in this space, but we feel that that is generalizable knowledge we need to share with learners. Understanding your responsibilities. A lot of it comes down to communication and communication strategies that we're smart people and we can learn how to talk and share information in modes of communication that really work for decision makers, whether that's social media, briefings, testimony, and other modalities. And then finally, there's a whole skill set around partnering with decision makers, again, through understanding what they're up against and learning to adapt our skill set to their world. And so these are real educational competencies that people can learn, and it doesn't even take a long time to learn these skills, but it's a really vital set of skills and awarenesses around where are the opportunities for me to be making an impact. We've been doing a set of stakeholder interviews with faculty around the university. We started off with a landscape analysis of UCSF to try to find all the cubby holes and places around the university where work like this goes on, and surprisingly, it's peppered throughout the university. There are lots of faculty who are part-time, sometimes even mostly full-time doing this kind of work. And we've been conducting depth interviews with them to try to understand what do they need to accelerate the work that they're doing, what are the challenges in this area. But one of the things that is the most inspiring is when you sit down and you talk to somebody who works with policymakers, most of what they tell you is how great it is and how meaningful this work is. A lot of them will say things like, it's the times when I felt I contributed the most, when I was able to actually work with people outside the university in positions of power and authority to make change happen. There's an interesting phenomenon that happens with clinicians, where clinicians are obviously trained to work with one patient at a time. And when you're a clinician treating patients, and you start to realize that actually the problem that I'm trying to treat isn't at the individual level, it's at the societal level. It's a social determinant of health. Clinicians often wake up to the fact that they start to just become frustrated, that I'm just cleaning up the mess after it's already happened rather than able to work upstream to make change happen. You see a similar phenomenon for clinicians, scientists who are working in clinical practice settings, and they start to see how misguided the various clinical pathways are that they're facing, and they start to become managers and to think about novel ways to restructure the health system, maybe even just within a unit, to make it more efficient or make it more effective or more equitable. And so a lot of these careers are coming kind of organically out of the circumstances that practitioners find themselves in. And it's when people realize that they're in a position where they can and have the skills to actually create a program, they get really excited, and it becomes a very, as this person says, I get immediate feedback. If the whole staff is working together more fluidly because of a set of practices that I helped set up, I get immediate feedback that this is a good thing. And I love this last quote. This isn't just a little service on the side. This is a big part of who I am and what I do at UCSF. To actually, this came from a scientist in our tobacco center who has been instrumental in changing really important regulations around menthol additives in cigarettes that are a racially targeted strategy on the part of the tobacco industry. So when people embrace this kind of work, they get really passionate about it. Just a few of the services and resources that we are developing that are either already available or coming online. As I mentioned, we've landscaped the whole university. It's a really big place. It's a really complex institution. And to be able to find all of the pockets where people are doing this kind of work, interesting places. I sit in the Institute for Health Policy Studies, where everybody there is kind of thinking this way. But I was surprised to see how over in our biotech facilities, you've got people thinking about regulatory science. So there's a lot going on this university that could be pulled together for greater impact. But we have this map, and we're building currently a virtual home that can be used by UCSF learners and faculty, but also would be available to our community partners and outside policymakers. That is a one-stop shop where you can find these resources around the campus, whether it's faculty working in particular areas of policy change or whole courses in this stuff. We have a consultation service now that's available for learners and scientists at the university, but also community partners around specific strategies for making policy change happen. Community partnership services as well. We are about to launch a UCSF-based pilot scholars program of people who get trained in impact-oriented scientific modalities. And this, one of the novel features of this training program is what we call last mile grants. So scientists who have a completed set of research studies or one study can use the grant to actually package and disseminate what they know to targeted policymakers around the state or the locally or federally or even globally. We've conducted, as I mentioned, a study to try to understand for people who do this work currently despite all odds, what are the barriers to making this work happen, and what are the things that matter to make these careers successful. And we have a public event series and speaker series. We just had our first one. We had Dr. Marion Nessel from NYU out. She's a world-renowned food politics researcher, and Marion has just published a memoir about her career, and she seemed like the perfect inaugural speaker because she embodies a lot of the principles of an impact-oriented scientist, and her whole career is one long arc of making policy change happen in a really challenging area for policymaking. And this is available online. And the other thing that was meaningful about this session was our plenary speaker was Catherine Lucy, who spoke about women in science and the unique barriers that women in science face. Okay, and I'm going to let Hilary talk a minute about strategic science.
So I'm just going to talk for a minute about strategic science because I think it's all well and good to talk about being more impactful in our work, but I struggled for a long time to actually figure out what does that mean and how do you actually do it in a way that works. And I have been very influenced by this construct of strategic science. Don't push the X or do push the X? Don't push the X. So what do you push?
The big green one.
Oh, the one in the middle. Okay, so strategic science is based on the idea that research is really, really good at speaking amongst ourselves and to other scientists, but we do a really poor job, as I alluded to earlier, of creating social change and policy change. And the question asked by Kelly Brownell and Christina Roberto in developing their concept of strategic science is, if we were going to create a research infrastructure that was in service of social change and policy change, what would be in that black box between research and social policy change? And they answered that the thing in the black box is all of these organizations, people, decision makers, change makers that have the power to make changes in our social environment, in our policies, in our systems, in our structures. And they may be legislators or regulators, it may be the courts or the press, it may be the public or nonprofits. It may be leadership in our own health systems and hospitals, they may be our professional organizations, but these people have power. They have power to change norms, they have power to change policies, they have power to change systems, and so we have to work in service of them. And a lot of this is based in the understanding that traditionally we're taught to do research in a linear trajectory that builds towards our own promotion. So we're trained in our research training for how to get our first job. And when we get our first job, what do we need to do to advance our research so that we'll be promoted to associate? And then how will we answer the next question so that we get promoted to full professor? And while that is all important, and we need to be promoted, that does not orient ourselves towards social and policy change. So how do we do it? Brunel and Roberto, in this wonderful, very brief article in The Lancet that I encourage you to download, would say it's because we're starting with the outcome of career promotion and not starting with the outcome of identifying that person who has the power to make that change. And that's the first step, to identify our change agent. And then we go to our change agent, either directly or through a nonprofit organization or an advocacy organization or a professional organization, and we say, what do you need to change this system or this policy? And then we ask ourselves, how am I going to go out and develop that data and that evidence? And that, in the language of strategic science, would be a strategic research question. And we go out and we answer that strategic research question on a timeline that's of relevance to policy. And then, very importantly, rather than just putting that information into a journal behind a firewall, we take it back to the change agent in the format that they can use to actually start changing policies and systems. So we can think about this in governmental policy. I think that's sometimes the easiest to do because we talk about that all the time in politics. But in fact, these policies are everywhere in the health work that we do. They're in our hiring policies, they're in the guidelines we're following from our professional organizations, they're in our preferred drugs and our treatment algorithms. They're in things like the number of social workers that we have in our clinic, the number of nutritionists and nurses and mental health providers. It's in policies like when telehealth can be used, whether staff needs to be vaccinated en masse, whether walk-ins are accepted. These are all decisions that somebody in our healthcare system is making, and they may be evidence-based and they may not be. And you can think of many, many others. So with that, I'm going to turn it back to Laura to talk about how we're going to use the rest of our time.
Okay, so we thought that we would guide the group through a activity that allows us to kind of think through the steps involved here. And so we can either do one big group, or we can do a couple of smaller groups at tables. And then, but I'm thinking that we can just do this as one big group. And we're going to have three rounds, and we're going to have a few minutes to kind of come to an agreement about what we want to work on together, and then a few minutes to kind of report out on each step. So the first question that we want to kind of we want to start with is, can we decide on a public health issue, challenge somewhere in the Bay Area that we would, like, the thing that is the most frustrating to you? Like, what's a health issue that just you feel like you've been? For me, it was the fact that chronic disease gets very limited attention because it takes so long for somebody to get really sick from chronic disease, and there's very limited resources for prevention. And how can we rethink that challenge? It's but what are the real challenges around health and health equity that drive people to even be here today? Yeah.
I was trying to use my loud voice, but that didn't work. I think about social drivers of health and our ability to address them in our healthcare settings.
Social determinants.
People like to say social drivers, I've heard, because it's not necessarily a determination of their health, but
Oh, I like that.
it's feedback I've gotten.
So I'm going to go back to, Hilary put that slide on strategic science. And I want to point out an important area that I'm not sure if you thought, but yeah, that one's fine. What's missing from this slide, and it's going to influence everything that we talk about, is values. And values is so important. If we were in Florida right now, we would be in a room right now asking how we're going to use science to prevent kids from getting vaccinated. Because that's what's happening in Florida right now. They have there's a strategy that's anti-science, that's going to use science. They have scientists that are helping them. But anyway, so I wanted to point that out because that also, values is so critical. We have to always clarify our values because in a sense, that's what ends up driving what we end up talking about, and that's where we end up going. And that's part of the challenge is that sort of out there, we end up butting heads with people who have different values and we don't clarify and build common ground.
Can I push you on that for a second?
Sure.
Is that using science to support not vaccinating kids, or is that twisting science into advocacy?
Yeah, so it's I think, I remember a long time, it may have been an undergraduate, I can't remember medical school. I learned a long time ago that science is not value neutral. That it is driven by, we do have values, we have ideologies, and the questions you decide to ask are driven by the values that you have. Mm-hmm. So I would to the people who are doing this, to people who I don't necessarily agree with, from their perspective, it's science, right? And they will look at data, and all of us have biases, and I think this is one of the challenges is that you just presented a binary, and the problem is that everybody sees they see themselves as being science-based in whatever they do, and so.
And this goes to a really important tension that I think a lot of people who do this work have, and it comes up if you talk to our government relations people. They'll be the first to say, well, we don't do advocacy. We do something else, but we don't advocate. And don't you get up in front of a bunch of, giving testimony in a governmental setting and say you speak for the University of California, because you don't. And there's a real tension here, but I think it goes back to this point you're making, Tomas, about values. And the other way I think about it is, especially in the area where I work, where there's like one side that wants to protect and promote health and equity, and another side, industry actors that really want to stop people from doing that. Say it's soda companies, food companies, but same in many areas of commercial determinants of health or commercial drivers of health. And again, it goes back to values and trying to find policymakers who are aligned with the values that we hold around health and health equity. So I think because you can't work with, you have to, if you're going to do this work, you have to find policymakers that are aligned. And some of that is driven by scientific evidence. My values in this area are, like health equity. It's a numbers game, right? You look at data and you realize, wow, we've really got a big gap between the haves and the have-nots. But it is, at the end of the day, you have to kind of know your values and find people in the decision-making world that share your values.
I would say that's fantastic, is how do you build a bridge to the person who doesn't share your value and develop an alliance with a common agenda? And because I think, to me, that's sort of our big, because some of the problems we have are so big, we don't have, it's like we have to reach people who think differently than us, that have different values.
Yeah.
And we sort of have to figure out how to close that divide, because that's what's keeping us from the last mile.
Right.
Starting with not saying social determinants of health, which is a big buzzword among certain people. I also want to say from a training perspective, we train people to communicate to policymakers scientific consensus, not our own research, because very rarely has any researcher's own research created enough evidence to be ready for policy change. So I think that also addresses your point that there is a lot of value, especially in values in any individual study in particular. So, okay.
In my experience, it's finding someone who's really aligned with your, and it's not just values, it's mission, goal, right? We want to prevent childhood obesity or childhood diabetes, and that is a goal of a policymaker, and we share that goal, and I happen to know a little bit of science around that. But then once that's happened, then there's opening that circle to include people like you're describing that are maybe not completely bought into that, but are willing to listen to the evidence and think about it, and you can build a broader coalition. But I think you're right, and I think it's probably in that first bucket, the identified change agents. Rolled up in there is identify somebody who cares about what you care about and what you know about. Amy?
Hi, I was at this morning's session, and I was just thinking one of the ways that I have made an impact in public health and policy is, a few years ago I wanted to run for office, and so I found myself in a lot of meetings, city council meetings, Alameda County meetings with like Democrats, et cetera. But I also had my public health hat, and I knew a lot of public health people who were very passionate about making change, especially in the Trump administration, era. And as I was sitting in those meetings, I just had my, ear open for like, if anyone said, I really need help with this, I would approach them and say, I have a public health degree, and I know a lot of friends who also have medical degrees who can help you advocate for what it is that you want. So it wasn't about so much about I wanted to do, but just seeing where I can help a need that was already there.
And so when you were in that position, did you work with scientists, or how do you even?
We had a club, it's called the Public Health Justice Collective. It's on Facebook, and we also have a listserv. So it was just an informal group of us public health students from UC Berkeley and SF State. And we just wanted to make a difference. We're like, we have degrees, but how do we, where do we even start? So we had many avenues, but one of my personal avenues was the policy one.
So this is my experience with people around the university. People sort of gravitate towards this work through Facebook, or it's very, it's not organized, it's not promoted as something you can do if you're an academic. It's something that you just sort of do in spite of everything. And, or through these, and when we went to Landscape the University, there are a lot of groups like that all around UCSF, people, just small groups, large groups, students, faculty, who are little pockets of this work. But the university itself isn't really fostering and supporting and promoting it.
Mm-hmm.
Any other? This is a really valuable conversation. Am I going the wrong way?
Yes.
Huh. It's interesting. So thinking about somebody suggested the social drivers of health as being a sort of broad issue that they care about. It's what gets me up in the morning too. But it's a really big area, and when you are actually trying to partner with decision makers and make stuff happen, usually it's got to be a more specific area. So I'm wondering, is there a specific piece of that, yeah?
To me, is chronic diseases, like you said, specifically high blood pressure. When I was an undergrad, I just was so interested in high blood pressure because my dad had an aneurysm. It was because, or related to high blood pressure. So I just began searching on campus to see if there was any projects that were working with patients with high blood pressure. And then I came across this research study that was doing it, so I joined it. I talked to the professor and everything. And it's just been so great to find out how much we can do just as a small group and to disseminate information that might help the community. But this is just an issue that bothers me that is not just in the Bay Area, but is in the whole nation, that high blood pressure just affects the minority community the most, Hispanics, Black, and African Americans. And so this is one issue that I would like to continue to work towards.
So hypertension, inequities in hypertension, and there's so many drivers of a problem like that. And it can be everything from people who don't have access to even knowing their blood pressure, therefore they can't get treated for it, diet, all manner of that's a really good policy issue that, and it's a classic. We sometimes call them wicked problems because it's been around forever and it continues, it gets worse, the disparities grow, and there are a lot of well-known interventions that are very well, studied and documented to work. So it's not like we don't know what to do. It's that there's a barrier between the knowledge. There's a knowledge and action gap.
Do you want me to throw out some policies and systems that we might think about in relation to high blood pressure, just to give us an example? So I'm just going to throw a few things out. We can think about too much access to ultra-processed foods in our environment that have a high salt intake. We might think about policies that dissuade Black and brown people from seeking out preventative healthcare services. We might think about the lack of food service guidelines in big institutions that might have some influence over the salt content in foods that are being served in airports and work sites and other systems that reach a lot of people. We may think about the challenges to getting your blood pressure checked in the community if you already have high blood pressure, and how many steps you have to go through to go to see the doctor or to get a blood pressure cuff at home. So maybe we just choose one of those.
And I would add the impact of racism persistent over the life course, and the stress associated with that and traumas associated with racism as a factor. Training clinicians to help patients access home blood pressure monitors and how to read them. Food pharmacies that have been documented to work, where people come in and get their blood pressure taken once a week, and they get a big crate of veggies on their way out the door, and it literally transforms people's diets. That's a program going on at the General right now. So any other ideas about policy systems, drivers of hypertension disparities? Okay, so, okay, who can change this? We can all change it, right? But who can change? Who's really in a great position to change this? And the thing is, when you start thinking about this, you realize, wow, there's so many decision makers at so many levels of the system who could play a role in fixing this problem.
I think with everything, funding is the primary, I guess, changer in this topic. If there's funding for programs that just like simply provide food weekly, like that's already changing something. So I guess whoever has the funding, that could change the way that we.
Yeah, and I just quickly push back on that a little bit, because funding's a precondition to making stuff happen, but if the funding isn't directed at the right kinds of programs, or if it's not allocated properly, and if implementation gaps occur, maybe funding isn't enough.
I just got the pass mic here, but then there's a person in front. But so I have two concrete examples where I feel like the state put funding into place. One, we both work on ACEs Aware for the state, and there's reimbursement for ACE screening. And part of what we're working on is like state implementation, just because you put the funding mechanism in, which is partly a barrier for people, but then there's all these other barriers around, our clinic's gonna implement them. What do they do when they screen? Like, how do they screen, and what do they do after they screen? Those are the questions that why people don't wanna do this, and because trauma, I think, is a player in things like hypertension. And then the other example I'm thinking of in this multi-sector work that some of us are doing is the care coordination, CalAIM policies that are really innovative, I think. And but then it's like, how do you, just because there's enhanced care management dollars coming, we're struggling with our health plans to identify what is the denominator for how many kids actually qualify for enhanced care management, because it's a lot if you actually look at the definition. But everyone has a certain idea about what enhanced care management, I think, looks like these high-end need, like hospitalized kids. But actually the definition's broader, and no one can seem to figure out how to get the denominator in our county. That's something we're trying to work on.
Anda, when you use the word "we," can you?
Who's in that? Like, who's in our system?
No. If I'm assuming that you are part of the "we," how did you get there? What did the institution do that allowed you to use some of your time and energy and brain power to support that work?
We have a foundation that supported us to do integrated behavioral health in our clinic at San Francisco General. As part of that, we argued for creating a toxic network improvement collaborative with the two managed care Medicaid health plans, DPH, California Children's Services, like the different multi-sector partners we have, to try and figure out how to make that sustainable. Things like that.
The key thing that you got to allow you to do this was money.
Yeah, some money, and also that the state has put in these policies that are providing money for change in our systems, but unpacking all of that and how that actually works on the ground. Community-based organizations can now bill for Medicaid for care management, but actually doing that is very, very hard. So most of them are like, no, thank you. So it's just
So money
reality.
and new state policies are influencing the type of work that you're doing.
Yeah.
I love that. Okay, cool.
Oh, hi, my name is Yuri. Hypertension, not my area of expertise at all, but I'll just venture to ask, so there's probably supply side policies and demand side. If you think about like salty food, I imagine it's the same for sugar sweetened beverages. Is it possible to regulate the amount of salt that's allowed in packaged foods that are sold in supermarkets? Does the FDA have the authority over that? Or is it like, oh, you can't dictate, what the max amount of like salt per, ounce of food or whatever. So then it's a tax on highly salted foods. Just thinking about, those kinds of levers.
Do you want me to answer?
Yeah, you go ahead.
I mean, this is a great strategic science question, so I'm going to answer this by giving you an example from the sugar world that I think is really helpful because it talks about our potential influence in product reformulation. And the issue was around how much sugar is in kids' breakfast cereal. And this example of strategic science, which I really love, was looking at the amount of sugar in different kinds of breakfast cereal, and then seeking out information about what the food industry would say if you tried to regulate breakfast cereal, or the amount of sugar in breakfast cereal marketed to kids. And there was actually an article in the Journal of the Association of the Nutrition and Dietetics written by somebody from Kellogg and someone from General Mills who made a couple of arguments, but one of them was that it's breakfast cereal that's fortified with vitamins and minerals isn't healthy if kids don't eat it. And kids won't eat it if it doesn't have sugar in it, and therefore, this is what we need to do to keep kids healthy. And so the strategic science question that came out of that was the researchers saying, that's actually testable. We can put kids in a room with a high sugar and a low sugar version of the same thing and give them access on the table to whatever extra sugar they want and whatever extra fruit they want, and test who gets the most vitamins and minerals and who gets the most sugar. And as you would expect, the kids who got the low sugar version of the cereal ended up getting lower sugar overall, and both groups of kids eat breakfast. So what do you do with that? Well, then when the policy making media came out about reducing sugar in breakfast cereal and calls for the industry to reduce sugar in breakfast cereal, the researchers, these particular researchers who were at the forefront of this, were very rapidly ready with the data. And they said, the food industry is telling you that kids won't eat low sugar cereal. We did the randomized control trial. This is what it showed. And obviously many other things were going on, but that was part of the genesis towards industry self-regulating decreases by, I think, 25% now in the amount of sugar that's in kids' cereal. So can't do that work alone, but I do think that similar examples could be thought about in the context of sodium and product reformulation.
But I love the way you said, couldn't something be done about this? Is it the FDA, right? And yes, absolutely.
We're waiting.
That's a regulation that could happen. You can put. The UK just did it for sugar, right? It's not something that can't happen. But what's so interesting, and this is such a great example that you brought up, because there are just so many layers to the problem. There are a lot of causes, and there are just many layers to it, and therefore the system is really complex, and therefore the policy opportunities are diverse and substantial. And you can imagine, you wouldn't necessarily, you couldn't pass a state law to regulate the amount of salt in packaged foods because, of commerce and so forth, but that it would be something that you could do at the federal level. And so often these are areas where, sometimes what I'm doing is just looking around like who in a position of power is willing and interested in doing something about this. And this is where we don't need to be advocates, because there are whole advocacy organizations out there advocating, and specifically around this issue. And so, Center for Science in the Public Interest can do that part. But as a scientist, I can play a role in this. And if there's someone in the ecosystem who I can find who shares the values and wants to make change happen, then partnering with that person or people and developing a policy change effort around it makes a ton of sense. You wanted to say something?
Yeah, I have a follow-up question. It also goes back to, thank you. It also goes back to the strategic science cycle that you showed, where I wondered where people with direct lived experience of the issue are situated, because they're not necessarily with the change agents. They often don't have the power, right? But they are an invaluable source of grounded research questions that may or may not be strategic. And so it's kind of incumbent upon us, because then I would ask, well, what do people living with hypertension, of all the many factors that seem, to be playing a role, what do they think is the most important to work on, and then find the change agents for that?
I think community, general public is on the previous slide, because you're right, empowered communities can have an extraordinary amount of power when it's leveraged in powerful ways. So I think that's super important, and that's one of the ways, not the only way, but one of the ways that community engagement enters into this.
And that, so especially because a lot of us care about health equity, understanding the community perspective on this is often really critical. And so, like, just going back to the example of the tax here on soda, that was started as a community engagement effort. And then it happened that there were people on the Board of Supervisors who thought, yeah, I care about that issue too. How can we work together? Tax was not the first thing on the list in the community focus groups. Education, water was on the list, water access, or give us something free that can substitute. It took some time to kind of figure out, come to the idea that a tax could generate proceeds, and if the proceeds were allocated by a citizens board of community stakeholders who know where the money is needed for water promotion or whatever it is that people need. So, but that's a really good example of where bringing community together with science, together with policymakers, nobody got exactly what they thought they were asking for at the beginning, but there was a negotiated compromise that worked for everybody. And that's an ideal kind of situation, if you can happen upon that kind of magic. But you're absolutely right. Community voice is, if we want to fix social drivers of health, we've got to have the community at the table.
Okay. Hi. So I come from a community health setting. I work in an FQHC. And one thing that I know is that a lot of our behaviors as a healthcare organization is driven by, in large part, a lot of this conversation about funding and grants and who do we report to. We care about UDS and HEDIS measures and all of that. So in regard to the hypertension conversation, because I work on other immigrant health disparities that aren't always included in the conventional UDS and HEDIS measures that are commonly reported, like hypertension. And I'm very well aware that those sort of outcomes that are reportable and are linked to dollars are very huge drivers of health organization behavior and what we invest our time and people in. And similarly with the COVID pandemic, we were still getting COVID dollars even earlier this year, even though things are winding down because it's residual from other cycles. And so what it does is it actually forces us to put more time and energy into COVID, even when there are potentially other more higher priority things going on. So yes, money does talk. Now, like I was thinking about these questions that you posted here, and other healthcare models like Kaiser, for example, and how they actually do put a lot of investment in the social drivers of health, like for hypertension, a lot of education about doing farmers markets and cookbooks and wellness programs to try to kind of get ahead of people developing hypertension. And I think their alignment of having like the hospital, the healthcare providers, and the insurance organization all aligned, and all the funding is in one bucket, and they know that they can save money as a whole entity if they invest in the upfront work. And so where I work, we actually have our own MSO, which is maybe not common for an FQHC, but we also do a lot of this preventative work because we know it'll save money for our organization. So I think that when we talk about like, oh, who do we identify as like the source of power? I think everything traces back to how are organizations getting funded? And if you can align everything just right, where the funding someone's funding depends on how well they do in taking care of the residents in this, state of California or in this jurisdiction, this county, then I think you can align to, achieve better health outcomes.
So
I appreciate, oh, sorry.
I just think what you're describing is incentives-driven policies. And that is often what is driving health system policymaking. I agree with you, is funding or efficiencies or value of some sort. And that's a little different from other sectors of policymaking. So in big P governmental policy, sometimes it's rule changes, right? You must wear a mask indoors, right? And so there are different levers. And what's kind of interesting about your example is that you can imagine using different kinds of levers in these different sectors. And often, in my experience, people aren't always thinking that way. That there are a lot of ways to skin a cat. And changing the rules of the game is one way to do it. Creating incentives for people is a different way of doing it. But there are a range of policy levers. And part of what's so fascinating to me about this kind of work is, and academics we're kind of trained to think this way. Well, what are the possibilities here? And sometimes we can come up with some pretty innovative strategies that are a little bit different from, but in health care policymaking at the systems level, often it's financial incentives.
But let me just call attention to the fact that the HEDIS measures themselves are a policy that
Right.
you are being held captive to, and somebody, an organization, is creating the HEDIS measures in a way that isn't, I think you're saying, evidence-based. It isn't working for our FQHC. And so I think the question here would be asking what data, who is it, NQF who develops HEDIS measures? HEDIS, or I don't know what it stands for. They're quality measures that healthcare systems and organizations have to adhere to and get scored on, and in many cases, funding is dependent on.
Insurance reimbursements.
Who is making the HEDIS measures, I used to know, and how can those people be influenced towards more evidence-based HEDIS measures? And those HEDIS measures are always being updated and reformed, and if that is your area of interest, and maybe this needs to be an area of interest of impact, how can we be influential in communicating that evidence to the places that it matters? Tomas.
Yeah, so power and authority, obviously legislators. And so Laura, you gave me an idea. You were mentioning how academicians have an incentive structure to focus on grants and peer-reviewed publications as a way. So that's what they do, because that's the incentive structure. And it made me think, we need to know the legislators, how they do it in a real concrete way. What are their incentive structures? And how do we connect the science to their incentive structure? So that would be strategic science. And I'll give you an example. And legislators, elected officials want to do things that get a lot of press. And they're looking for low-hanging fruit, things that they can implement that their constituents like. And there's sort of waves of opportunity. Like right now, there's a lot of interest around opioid overdoses. So a bunch of legislators are just, they're trying to pass their own bills. So we have to figure out how to connect that intrinsic motivation to science. It's almost like we need to be ready, sort of have a queue of policy agenda menus that are science-based and ready for these waves of windows of opportunity that come. Because when they do come, because they need it and we have it. So anyway, I'm just throwing this out there. So it's almost like you need a collaboration between you guys and a political scientist. I'm not sure who studies legislators, but I'm just throwing this out there.
That is a great idea. I love that idea. And what you said about menus is that's really what, in my experience, what people love to have. They say, what can I do about this problem? And you give them a menu, and with lots of variation in the things that they can do. If they want to discourage consumption of tobacco, you can put a warning label on it. You can plain package label it. You can tax it. You can, there are all manner of things. Tobacco cessation programs, right? So you give them a lot of options, and ideally score them in terms of, we have a lot of evidence, we know it works, here's the size of the effect you can get, so that you're really giving them a lot, because they love that. They love to have lots of options, because in their world, in my experience, they're very constrained by what is politically possible. And so if you don't give them, and I think in academia, we're to the extent that we think about, the policy implications at the end of your article, we're never trained to think about, well, what actually is doable for somebody? And that will vary, but I love the idea of, I love your idea. I think it's great. And to have sort of at-the-ready menus of things. There's a guy up in Canada who tried something kind of like this, a sort of one-stop shop of menus for different health outcomes. But I think it was too, I think there was some traction with healthcare decision makers, but not so much with governmental policymakers, because they're not like online searching for evidence-based policy menus. But I love the idea of the incentive structure. And the challenge there would be, maybe it's going to vary by, some policymakers are really, really beholden to lobbying to the funders and dark money and all of that. So it's kind of hard to know. And
right,
what?
Lobbyists. What I'm describing, I believe there's firms that specialize in doing what I'm describing right now, but they do it.
Yeah. They don't work for us.
Right, they don't work for us. So it's almost like we have to figure out how to do that best practice.
Yes.
Because they're helping them get that. The legislator needs a bill. Here, I have one for you. And
Yes.
They have come from an industry lobbyist.
It was written by Alec.
But we're working on being better at doing that, so that when it's time and you want the bill, we have partnered so that it's ready, written out for you.
Really interesting.
Hello, my name is Theo. I think in conjunction with that discussion of having the menu available, the different policies available for when the opportunity is there, especially with the tobacco work, and especially with the funding, the work that I do is funded by the taxes on cigarettes. We work through the Tobacco Disease Research Program, and we're studying smoking cessation. And I think that without the existence of that line of money, we would not be able to do the research that we're doing. And so the work to get that funding is also, I think, important in terms of the discussion, and as available as a thing to bring up in terms of what opportunity is there. We're looking for something new to bring to the table legislatively, and it's, we should budget funding for this opportunity or this field.
And this goes back to the point about financing, that funding drives a lot of this, and one of the beauties of taxation is that it creates funding that doesn't go into the general fund. It's actually allocated to fix the tobacco situation, right? And so
One of the things that this brings up, since this seems to be a big interest of the group, the CDC has a science impact framework where they talk through all the increasing levels of impact that you can have as a scientist. And in that middle level, they really talk about the funders as being one of these change agents, that we have to be able to also influence funders towards funding those things that are evidence-based. And I think there's some good examples here in NIH policies and how NIH policies have evolved over the last decade towards increasingly funding work that's related to social drivers of health and health inequities. And I think that's been a substantive change. certainly has been for my health disparities career. So I appreciate that.
Okay, so the idea was to come up with, we're trying to think about hypertension disparities and who is a target. You know, often it's kind of challenging to figure out who the target policymaker should be for addressing the issue. But just going back to your original example of your dad, what do you think would have made a difference? Who's in a position of power to change his trajectory in this area?
Yeah, my research that I'm doing works a lot with providing education, and I think like I've always been passionate about just preventive care. And the way that I think about is if that person had received some information regarding to just high blood pressure, then maybe that person would have made better choices. And so the research that I do is whether having a health coach provide you with that information helps you. And so far, we're seeing a decrease in high blood pressure. And also the Kaiser Permanente has that they use 2 medications instead of 1. And so that extra medication might not be covered through Medi-Cal, but 1 is. So how can we get that second medication covered through Medi-Cal?
So I think where you're headed in the ACEs aware person was as well, it is a sort of health systems policy change that would make some form of hypertension monitoring and awareness more available to patients, right? Okay, so that's a small, that's a non-governmental policy, that's a health plan deciding that they're going to put some money into investing in this as an opportunity for patients. And the FQHC
Well, I would say another layer to that is access. So let's say that this person did not have insurance, and so there's no healthcare organization that's responsible for an uninsured patient. So I think a lot of things go back to like universal health care and, you know, this setup that a lot of countries have adopted, but we haven't, and it's not unclear how feasible that is. But, you know, if there was some sort of national healthcare system, then we would deem all residents or, you know, citizens and hopefully non-citizens as people that were responsible for keeping healthy. But without that, then there are people who are left in the dark who aren't covered by the system right now.
Right. So in our piecemeal system, we've got Covered California, right? So maybe the target policymaker is Alice Chen, who is, and convincing her that we need for anybody on Covered California, which includes a pretty broad swath of the population, they get blood pressure monitoring and education and coaching in this area. So
a lot of health plans, maybe even Covered California, don't cover the blood pressure monitor. I know Medi-Cal does, but Medicare only doesn't. So that's an issue. And you know, as an FQHC, we actually do see everyone, self-pay and, you know, insured and private, everyone. But again, if I could use UCSF as an example, like, UC does not accept everyone. And so like that kind of patchwork, piecemeal frame, someone gets lost in the system if they don't have anyone near them that can see them.
But your comment really speaks to the complexity of this, especially in a multi-payer system. There, just one, you know, I'm, you know, trying to get us down to like one change we want to make, and there are just still a million possibilities for how you.
And we've settled now on something that, to me, feels like simple, doable strategic science, which is what would it cost for Medicare to cover blood pressure cuffs for a certain eligible population, and what would they get in return for that investment? That's the kind of thing that I think we as researchers can either study or try to extrapolate from the existing literature.
Yeah, another aspect of access that I was thinking is I mean, people can be educated, but if you cannot buy the food that you need, education by itself is not enough. So who do we have to influence so communities can have a Trader Joe's? They can walk to Trader Joe's and buy fruit and vegetables that are cheaper than Safeway, or any kind of place where they can buy what they need in order to be healthy. So I don't know who we need to influence in order to have that, but that is another piece of access.
Absolutely. And you know, this is the problem with these, you know, the wicked problems that just are really, they're multifactorial, and there are a lot of policies that probably need to happen in order to get traction on it. But it can be known, it can be studied, and you can chip away at it one step at a time. The beauty of taxes is, again, you mobilize resources for more research, and there's a sort of virtuous cycle inherent in that. But so there are strategic choices around where do you want to kind of enter in, and what's the first policy that we might want to change to get because sometimes you can set off a virtuous cycle like what we saw with tobacco. Yeah, next. Okay, so what kinds of data do we need to?
Let's go on to the next question.
You kind of, yeah. Okay, so given, I think where we're headed is we know we want to fix hypertension disparities. We know that there are a lot of ways to go about doing this, but we're kind of wanting to focus on patient education monitoring, and even that is still a really complex area because there are a lot of payers, there are a lot of ways to go about doing that, and it may be things like Medicare policy around devices and so forth. So our next question is what kinds of tools and other things, especially for the people who are our community, our partners, what are the kinds of things that would be helpful for us at UCSF to provide and offer as supports for you to approach your change maker with, your policy maker. So, I mean, you're in an FQHC, and what are the kinds of resources that UCSF has to offer that could help support efforts at policy change within your organization?
Well, so I work mostly on TB and Hep B, and I have been working with Dr. Priya Shetty on our TB work. One big problem for us is that like TB screening with quantiferon is not covered by Medicare, even though it's a preventative service. And one of my hypotheses is that the USPSTF doesn't do a great job of covering risk-based preventative services that affect maybe minority populations, or they just haven't caught up. They may be slow to match up with the USPSTF guidelines. And so this is a CMS issue, which is like a really hard one to get to. They change very slowly. But, Dr. Shetty connected us with Alice Chen, since she's covered California. I think she had some experience with CMS at some point, but I think it's really all about power and connections, really. A lot of UCSF researchers do know other people who maybe do go on to work for government or other high leadership positions. And so connecting, our community health level data saying, we try all these, logical ICD codes, they never work. People are developing workarounds and using like TB close contacts, like just to get it covered, even though that's not necessarily the most appropriate thing to do. Providing that community level data to key people who can get into the ear of CMS. Like, I feel like that was a valuable kind of thing that, our UCSF partners were able to help us with.
That's great. And how was it that you found her and started this collaboration?
Well, I think a lot of FQHCs work closely with departments of health, and so we've always had a long history of collaboration with SFDPH and also CDPH, because our health center has a lot of TB. We have a lot of TB cases, and so we've worked with them on that. And they told us about the CDC Best grant, and so they thought it would be a good idea for us to work with UCSF and Priya's team, because they did cost effectiveness, implementation science, and to work together on that grant. And we applied and we got it, and so we've been working very, very closely for the last year and coming up with these, identifying these very obvious barriers to implementing really good latent TB testing and treatment. And so, this insurance thing that I just used as an example is one thing where we're trying to figure out how to get this up into the policy decision maker level to implement a change, because otherwise it would seem so impossible for us as just like a community health center to change that on a national level.
And to have the capacity to generate the kind of data that you need in order to make the case.
Yeah.
And so it was through the health department that you found her.
Yes.
And can I build on that for a second? Because I think you make such great points about connections and networking and who you know. And I just want to emphasize that I don't think every researcher needs to be knocking on doors of every legislator or CMS or those things. In many cases, the go-between in my own work has been with an advocacy organization or a professional organization that holds those relationships. And what I'm able to do is be the person who develops the science brief, the one-pager that the advocacy organization, who's an expert at lobbying and who holds this relationship, is able to take to the person at, in my case, it's not CMS, it's USDA, to say, this is the evidence-based science and this is the evidence-based policy that would come from it. So I think you make such a great point about the power of those relationships, but we don't all have to hold those relationships ourselves. And so that's one thing we're trying to do, is help to create the connections with the organizations that can be the go-between.
So what else can UCSF do to support the work that people in the room are doing around policy change?
I come from an anthropological background, so I'm a little bit biased in favor of qualitative data, but I have found that the combination of qualitative and quantitative data for people who are interpreting the science and potentially would be change makers, it very much humanizes the data to have this qualitative analysis of the participants and their experiences. Because it's one thing to say we can, in the example, we can give blood pressure cuffs to the people who are qualified under Covered California. It's another thing entirely to have, I wouldn't necessarily say a testimonial of a participant who was given a blood pressure cuff, but to see that that has a real impact in more than just numbers is, I think, potentially another way to support that. That's great. That's great.
Yeah, they always tell you that when you talk to politicians, you need to, don't just focus on numbers, you need to tell stories too. Stories go a long way in making the numbers make sense.
I can jump in on something I was thinking of. I think it would be helpful for UCSF researchers to translate their research into plain language, because our change makers are not going to understand the complex science, and then potentially the person who's working with the change maker, they cannot necessarily interpret the science into plain language. So getting our researchers to learn the strategies of how to speak with other people who just do not have the same acronym knowledge or the same science knowledge.
Yeah.
Hi, I'm a clinical research coordinator, mostly working in sickle cell disease. And at least with my PI, she has made it a point in her research to formulate a community advisory board where she regularly meets with focus groups, task force, gives them kind of like an idea of, hey, we need to create you know, a PR message to the community about XYZ affecting the sickle cell disease community. And I think that would be helpful for a change maker to hear, oh, we've already done kind of focus groups. We've already heard what the community wants. This is how we can present it to the larger, you know, public and to get buy-in from them about these changes and see how they feel about it. So I think that's one thing that could help with the tools.
Okay, so I think we should close things down unless there are any further comments. This has been really, really interesting conversation. And I'm glad that we got to kind of have a back and forth. That I feel like I've learned some things, and we'll take away a few really choice ideas about where we can go with this program. So thank you.
Thank you all.